Hello everyone. Let me just share the screen. Okay. So let's move to the part 2 of neonatal X-ray chest. And in part 1, we learned a structured and organized approach to X-ray chest, and we used the mnemonic Dr. ABCDE. The D stood for details of patient data and date. The R said about reading the X-ray quality, and we said we used the rotation, inspiration, and penetration for quality assessment of the X-ray. Then we said we would look at the airway, hilum, mediastinum, and the lungs, followed by bones and soft tissues, followed by size, shape, position of the cardiac silhouette, looking at the domes of the diaphragm, not to miss the costophrenic and the cardiophrenic angles, and then look at etc. with which the baby was not born with. And we said we would look at lines, tubes, catheters, and lastly, we would look at F, and that is the fundic bubble. So now I won't go into all of these, but now focus in this session on diagnostic patterns that you would come across for common medical and surgical lung diseases and identify variations and complications arising thereof. Okay, now look at this X-ray. This is an X-ray which shows bilateral uh, reticular pattern, which after some time in addition also shows air bronchogram. Further, you find that the cardiac and the diaphragmatic borders are indistinct but still visible, followed by diffuse, bilateral, homogeneous, generalized, symmetrical opacification suggestive of a respiratory distress syndrome in a preterm infant. So what we have here is a low volume lung with a spectrum of severity based on variable degree of surfactant deficiency. And mind you, it also is a reflection of whether antenatal steroids were given to this mother or not. So essentially, the first, second, third, and fourth grade of respiratory distress syndrome tells us the severity trend. Anytime you find grade 3 or grade 4 variety of respiratory distress syndrome, this is taken as moderate to severe form of respiratory distress syndrome, and you would need surfactant and definitely non-invasive or invasive ventilation for these, versus for grade 1 and grade 2 you could get away with non-invasive measures with or without surfactant. So the point here is low volume lungs, air bronchogram, diffuse bilateral homogeneous reticular granular pattern, which shifts over to diffuse homogeneous whiteout lung suggestive of severe RDS. Now look at this baby, who also is a case of RDS, a preterm with respiratory distress. But here you find that the lung volume is good. That means this baby probably has received a form of respiratory support. We don't see an endotracheal tube here. So this baby has received non-invasive respiratory support, probably CPAP, which has led to bilateral good expansion of the lungs. But look at this baby. The same baby on CPAP has both the domes of the diaphragm flattened out, and you find that more than almost 8 posterior ribs are visible, telling us that this is expiratory film. So this is a hyperinflated X-ray because of over distension happening because of higher pressures being delivered by CPAP. Now look at this X-ray. What we find is that there is an endotracheal tube in place, but following surfactant administration, there is uneven improvement in this case of respiratory distress syndrome. So why is it that one lung cleared whereas the other lung has not cleared? This is simply because you have intubated and have probably introduce all the surfactant into the right main bronchus, thereby preferentially opening up the right lung, leading to a collapse of the left lung, and therefore you find a white homogeneous left lung shadow. Okay, now uh, so that is one common complication that you should be aware of. And now look at this baby, the same baby post surfactant, instead of improvement, you find that there is diffuse, bilateral, extensive, symmetrical, homogeneous opacification. So what we anticipated was recovery following surfactant administration, but here what we demonstrate is deterioration. And when such deterioration takes place, we would think in terms of a whiteout lung. It could be because of pulmonary edema, or it could be a pulmonary hemorrhage, or it could be a condition mimicking RDS. And we need to be aware that pulmonary edema and hemorrhage would also cause a whiteout lung, so also a severe form of RDS. So what we have seen here is a spectrum of radiological changes that are seen with the disease, following intervention for the disease, and complications of which we should be aware of. So just to summarize, RDS classical features would be a low volume lung, air bronchogram, diffuse bilateral reticulogranular pattern, which is symmetrical, and in severe cases, you would get a whiteout lung. Now look at this baby. This is a baby who has respiratory distress, a term baby. What you find here in the first X-ray is bilateral uh, increased vascular markings, which are showing increased hilar vascularity. And the same baby, 24 hours down the line, has clinically stabilized. You don't find any hilar streaks, and the cardiomegaly, which was there, has subsided. And this is classical of transient tachypnea of newborn, a condition which is a diagnosis of exclusion, self-limiting, and a retrospective diagnosis. So a term infant who has undergone elective cesarean section, or where the delivery has been precipitate, and in near terms and term infants, you would see these features which are self-explanatory. Now look at this baby. What started as respiratory distress in this baby with prominent bilateral hilar vascularity, you find that the baby continues to have respiratory distress which is worsening. So what started as TTNB seems to have deteriorated, and in fact the baby starts becoming more and more hypoxic. You find that there is no cardiomegaly, there is no predominantly lung lung pathology, and you also find that there is no murmur. At this stage, you do a 2D echo, and time and again, when you have obstructed TAPVC, it is a great mimic of coming as persistent or refractory respiratory distress, and literature supports patients being diagnosed as chronic lung disease, which ultimately turns out to be a TAPVC. So if you have a refractory respiratory disease, think of uh, TAPVC and obstructive form. Obviously, it is a spectrum that you would need to know of. Now look at this X-ray. The lung volume is quite good, but you find diffuse, asymmetric, non-homogeneous, variable opacification more on the right lung fields compared to the left. And this is patchy consolidation. In presence of meconium stained liquor baby, we would describe it as meconium aspiration syndrome. Now look at this baby, and these are two dreaded complications of meconium aspiration that you should be aware of. One is sudden deterioration, and what you find here is that the lung is collapsed, the lung margin is clearly visible, there is air which has accumulated beyond the lung margins, telling us that there is a pneumothorax. The ipsilateral dome of the diaphragm is pushed down, and you find there is a shift of mediastinum. Now, all these four features suggests that this is a tension pneumothorax. A tension pneumothorax uh, can is a medical emergency. One needs to tap the second intercostal space, or as early as possible put in intercostal drain to reduce the tension pneumothorax. Now look at this X-ray. This is again good volume lungs, but what you find here is diffuse blackness of both the lung fields, suggesting that it is air only which is there, and there is hardly any uh, uh, any other pathology which is visible. The cardiac shadow is normal. The baby continues to have respiratory distress, and more importantly has persistent labile or refractory hypoxia. So what you are classically seeing here is uh, mm, black lungs, which is the hallmark of PPHN. So anticipate these two complications in all and every newborn with meconium aspiration syndrome. Now look at this X-ray. This baby again has air which is accumulated on both the lung fields, and it seems to have uplifted the thymic shadow, giving rise to a bat wing appearance. And this is classically what is called as a pneumomediastinum. And at times you would have a collection of air radiolucent shadow along the right, the left border of the heart, and the inferior border of the heart. More importantly, it appears as if the heart has been lifted up and there is a halo surrounding the heart, and this suggests that it is a pneumopericardium. So what starts as a meconium aspiration syndrome with bilateral lung involvement, complications that need to be anticipated are spectrum of air leak disorders in the form of pneumothorax, pneumomediastinum, pneumopericardium, and refractory hypoxemia, which can come as black lungs, what is called as PPHN. Now look at this X-ray of the same baby with meconium aspiration syndrome. What you find here is uh, uh, whiteout kind of appearance, telling us that there is hardly any air and the lung volume here is decreased. What is happening here is meconium has caused surfactant inactivation, giving rise to secondary surfactant deficiency. So this is how meconium aspiration shows a spectrum variation, and a high index of suspicion is needed, and you need to be geared up to anticipate and act quickly once such complications set in. A good way to substitute an X-ray to pick up a pneumothorax is to use transillumination bedside, and obviously you need to darken the room otherwise. So to summarize, meconium aspiration syndrome has normal to increased lung volumes, and you find that the lesion may be asymmetric, diffuse, non-homogeneous, patchy consolidation, and uh, this newborn is at risk for multiple complications of which we just talked about. Okay, now look at this baby. This baby has a spectrum of changes which are getting reflected. Now, what starts as a reticulogranular pattern with air bronchogram and endotracheal tube, which is quite high in the air column, where we made a diagnosis of respiratory distress syndrome, there is increased worsening of diffuse bilateral granular opacifications with prominence of the air bronchogram. The cardiac silhouettes has become indistinct, and you find in addition the changes which show transient uh, uh, cysts interspread with bilateral diffuse linear streakiness, and ultimately these cystic areas having become more obvious. And what you are showing here is RDS to begin with, which becomes more severe during the second stage with increasing opacification to develop translucent cysts to end up with obvious cystic lesions. And what here we are finding is chronic lung disease, which has been classically seen as a sequelae in very preterm babies who have been exposed to prolonged ventilation. And the chronic lung disease can end up with air leak syndrome spectrum, And one should be aware that there is no single X-ray per se, which is diagnostic. It is all a spectrum that one needs to be aware of, and a trend, and more importantly, interpreting it, looking at the clinical pattern of the baby. Mind you, these lesions are predominantly interstitial, and therefore you see diffuse bilateral uh, symmetrical lesions to begin with, which becomes asymmetrical and then localized and maybe develop complications in the form of air leak syndrome. Now look at this baby. What you find here is hyper. Uh, you find that there is opacification which is affecting the right upper lobe. There is no shift of mediastinum. The lung volume is normal, and what you have here is a single lobe which is affected with an air bronchogram which is visible, which is unilateral. So this is obviously a lobar pneumonia. But look at this baby. What here you find is diffuse bilateral non-homogeneous, non-symmetric patchy opacification, and with vague borders of the heart and the diaphragm with cystic areas which are visible in between. So what is happening here is a diffuse bilateral lung pathology in the form of lobar pneumonia, which is being looked at. And look at this reticular pattern, which is bilateral, symmetrical, giving rise to a ground glass like appearance. So, what you have here is an interstitial pneumonia. So, mind you, pneumonia has a spectrum on radiological appearance. It could be restricted to a lobe, it may be bilateral diffuse with affecting the both the lobes, or it may show a reticular pattern which is symmetrical with ground glass appearance, suggestive of interstitial pneumonia. Now, look at this X-ray. What it shows here is a left hemithorax which is black in appearance, and we said whatever is black has air in it. But what also is clear that this is not a pneumothorax, simply because you can find the visible lung margins here. So this is a space occupying lesion which is filled with air, which is pushing the heart to the opposite side. So there is a mediastinal shift which has taken place, and this is a space occupying lesion affecting the left lobe. Classically, this suggests chronic suggests a congenital lobar emphysema, also called as congenital lobar overinflation. Now look at this X-ray. What you find is the right hemithorax, which is black. So there is air which is accumulated. Lung margins are visible. So this is not a pneumothorax, but it mimics a pneumothorax. Somebody put in an ICD in this pneumothorax, thinking that it is a pneumothorax. But obviously the baby has not improved, because this is indeed again a congenital lobar emphysema affecting the right lobe. And look at this X-ray, which is almost mimicking a congenital diaphragmatic hernia. And we find that is shift of mediastinum, cystic areas with intact diaphragm. So it takes away the diagnosis of diaphragmatic hernia. What here is we are seeing is a congenital cystic adenomatoid malformation of the lung, also called as congenital pulmonary adenomatoid malformation of the lung nowadays. And here what you have is a whitish structure. So this is a soft tissue shadow which is not restricted to a particular lobe of the lung. It is causing some displacement of the air column. So this is a space occupying lesion. You would need a lateral X-ray to confirm, and this turned out to be a congenital cystic adenomatoid malformation of the lung. Now remember, the whenever a diagnosis of a space occupying lesion is made, you would need a CT scan of the thorax to identify the exact location and the vascularity. So these were some congenital lesions that you should be aware of. Now look at this pocket of air which is seen on this X-ray chest. But what is classical is it is not restricting itself to any particular pattern of the lungs. So it is in the lungs, it is extending onto the abdomen, and it is quite well defined margins which are going also beyond the lungs. And this is not a space occupying lesion, cystic lesion, but this is a whole of the incubator through which the X-ray beam passed, giving you an iatrogenic appearance of a lesion. So be aware that you must look and interpret the X-ray looking at the clinical picture. Now look at this X-ray. What you find here is again a diffuse bilateral lesion predominantly affecting the right side. There is uh, rotated film that is obvious, and but the baby appears to be otherwise well. This is nothing but the bedding of the baby which came in the way and gave rise to this artifact, mimicking almost an interstitial lung disease. And therefore beware of all these iatrogenic problems that you would look at. And then the resident runs to you to say, sir, there is a clear cut demarcation, and there is a pneumothorax which is there, but you say that the lung margins are well visible. The fold that you are seeing here of the lung is going beyond the lungs, in fact. So what you have here is a skin fold mimicking a pneumothorax. Now look at this X-ray. What it means here is that time and again you would be missing subtle findings, or you would not be able to come to a clear diagnosis unless and until you develop a habit of having a structured and organized approach, looking at the clinical picture of the baby first. More importantly, try to avoid making an impression on your colleagues by looking at the X-ray at sunlight, because you would be missing many of features on these. And so also the tendency of interpreting on the WhatsApp again is not a good way by which you would interpret an X-ray. And therefore a viewing box or a digital plate, a film on a digital media is obviously something that you need to be looking at. So what did we learn in this session? That diseases itself are not seen on the X-ray chest. What you are seeing is a two-dimensional representation of a three-dimensional object. Beware of artifacts, improper techniques, and patient movements which may mimic and give a false impression of a disease. The X-ray doesn't help us in identifying a solid from a cystic intrathoracic mass. At times, you would have an antenatal ultrasound which is abnormal, suggesting a lung lesion, but an X-ray chest which is normal, and this is classical of congenital pulmonary adenomatoid malformation of the lung. And in such situations, to distinguish solid from cystic lesions, and where a diagnosis of CPAM is suspected, one would do a CT thorax. And therefore, we must be aware of these two limitations of X-ray. And lastly, let us be more structured and organized in interpreting the X-ray. We talked about the doctor ABCDE approach. Let us not jump to a diagnosis just because we have found a clinical abnormality on the X-ray, but so also look at other and uh, obviously not to miss subtle associated anomalies which are there. Always take a differential diagnosis, and last but not the least, interpret X-ray in light of clinical condition. Thank you very much for your patient hearing, and uh, I would be happy to take questions if any.